Okay, great. The recording has started. So it's my pleasure to welcome all of you to this talk by Dr. Ravichandran and Professor Krishna Kumar. We also have as panelists Dr. Suresh, Dr. Shivakumar, and they will also be contributing some of their insights that they have developed over the past few months doing these tests. So I just would like to take one brief moment to introduce Dr. Ravichandran. Dr. Ravichandran is in heads the Institute of Nephrology at Mayotte Hospitals, and he's one of India's most renowned nephrologists. And he has had a career that spanned over 30 years and has treated more than 20,000 national international patients with various kidney ailments. And Dr. Ravichandran has won a number of awards during the course of his long career in medicine. And most recently, he, along with Professor Krishna Kumar, have been looking at efficacy and safety of Indomethacin to treat COVID patients, about which they will be talking today. Professor Krishna Kumar, of course, is well known to our IIT community. He is a professor of engineering design, and he has been working on a wide variety of topics, ranging from, of course, he's a continuum mechanician at heart. I mean, I am too. And of course, he's worked on electric vehicles and parameter identification, all the way to cardio biomechanics, and most recently on Indomethacin as a COVID treatment. Without further ado, I would like to welcome all of you to listen to this very interesting and very currently relevant talk on the efficacy and safety of Indomethacin to treat COVID patients. One last announcement is, if anybody has questions at the end, we would definitely would like to take them. You may have to raise your hands, and Dr. Ratna Kumar, who's my co-host, and I, one of us will unmute you, and then you will be free to ask the question.
No, thank you.
So with that, I'd like to welcome Dr. R.C. and Professor Krishna Kumar to present the talk.
Yes, Professor.
Good afternoon, everybody. I thank Professor Srikanth and Professor Krishna Kumar for arranging this presentation. So I have been in practice for almost 40 years, and I'm a nephrologist, as Srikanth told you. And one of the things that we see in nephrology is we have been very familiar with the use of Indomethacin. Indomethacin is a powerful anti-inflammatory drug which was first patented in 1960s for treatment of rheumatoid arthritis. So if you would realize that many of the medications that have now come for COVID are all basically treatments of rheumatoid arthritis, because inflammation is the common factor between arthritis and COVID. If you take the common platform, it is inflammation. So the outcome is bad in COVID because of the inflammation, not directly by the virus. So in kidney disease, we see a unique condition called pericarditis, where when the kidney failure is advanced, the lining of the heart gets inflamed, and that's called pericarditis. And the only drug that works in pericarditis is Indomethacin, even now. That is, since last so many years, more than 40 years, this is the single drug that works for uremic pericarditis. Similarly, after a bypass surgery, if the pericardium which surrounds the heart gets inflamed, what's called a Dressler syndrome, again, Indomethacin is the only drug that works. So, of course, it has also been used for other purposes in nephrology for reducing the protein loss in the urine. What is more interesting is the antiviral action of Indomethacin, which has gained recognition since 2006. So in the laboratory, it is a broad spectrum antiviral drug. It has been efficacious against SARS-1, against SARS-2, against cytomegalovirus, against herpes virus. It has been patented for a broad spectrum activity in the US. So it has anti-inflammation, it has antiviral action. And another interesting place where we have used it, actually we have experienced, is in 1989 for treatment of rejections after kidney transplant, a drug was used called OKT3. Now this OKT3 used to produce such powerful so-called cytokine storm. You inject it into the patient, he will get high fever with chills, breathlessness, drop in oxygen. The drug was very efficacious, but it had this side effect. And we found that when indomethacin was used to the patient, primed, we could use this OKT3 drug without the manifestations of cytokine storm. So this is very, very interesting that even recently, I sent it to Krishna Kumar. Somebody in Germany has said that he has used in a couple of patients, he has published it to prevent cytokine storm in severe cases of COVID. So we are experienced with the prevention of so-called cytokine storm also. Of course, other interesting action is at a low dose like aspirin. See, indomethacin again is classified as a non-steroidal anti-inflammatory drug. It is very unfortunate that all these drugs, there are a number of drugs in this group, they are all put together. See, some of them have a side effects like kidney deterioration, kidney function deterioration, or some other side effects. But the whole group gets a bad name because of that. Indomethacin, it's relatively safe. It has been used for several years. And even the deterioration in kidney function in rheumatoid arthritis, it has been used for several years without deterioration in renal function. Whereas nimesulide is a drug which is also classified under non-steroidal anti-inflammatory drug, but it has been banned by the FDA because it produces kidney failure. So the ordinary doctor gets scared. When he says, oh, it's a non-steroidal anti-inflammatory drug, he thinks of deterioration in kidney function. So as I said, it is like aspirin. At a low dose, it has an antiplatelet action. This antiplatelet action, again, is very interesting because it will prevent clot formation in COVID. So normally now if you see what they do, they give a treatment for anti-inflammation, high dose steroids. They give an antiviral drug, remdesivir, and then they use heparin as an anti-clotting drug. So they are using different drugs, but each of them have their own side effects and problems and still not able to achieve sufficient cure of COVID. It is very sad to see in the paper even today that India probably has lost 50 lakhs patients due to COVID. See, we have been trying since March 2020, so more than 1.5 years, to get this indomethacin to be used. It's unfortunate that we have not been able to push or get it into the guideline for treatment of COVID. Because it's only when it comes in the guideline of treatment, the ordinary doctor would be bold enough to use this for treatment of, because he is worried that tomorrow he may be questioned. So he is not experienced with this medicine. Unless and until it comes into the guideline, there is a reluctance to use this drug. And of course, the last advantage of indomethacin, again, which is amazing. Actually, to me, it looks indomethacin is a tailor-made drug for COVID. The last thing is the anti-bradykinin action. Now, bradykinin is again a chemical substance which produces both cough and muscle pain in COVID. There is a group of drug called angiotensin converting enzyme inhibitor, that is ACE inhibitor, like lisinopril, ramipril, etc. They are used for treatment of blood pressure. When you give this drug, the side effect is cough. And this cough is produced by bradykinin. This drug prevents the breakdown of bradykinin. The only drug that effectively stops that cough is indomethacin. So it has anti-inflammation, it has antiviral, antiplatelet, and anti-bradykinin action. So the scientific basis to use indomethacin is phenomenal. Then why is it not being used? I think two things are a problem. One is people are not familiar with its action. I think they group it along with other non-steroidal anti-inflammatory drugs. Thirdly, it is very cheap. It's hardly the treatment of COVID comes to 50 to 100 rupees per patient. So I think this has been detrimental in promoting the drug. Such a cheap drug, either doctor or the patients are not ready to really believe that it would work. I think I will ask Krishna Kumar now to present the scientific evidence what we have brought out for the use of indomethacin in COVID. Thank you.
Thanks, Dr. Ravichandran. We call him Dr. RC, very affectionately. I know Dr. RC for the past 30 years. 1989, I was introduced to him and I know him for 30 years. And in fact, we designed and manufactured what is called a CRRT, a dialysis machine, for about 50,000 rupees in 1994. In fact, at that time, there was no startup and all those concepts. So, in fact, we produced this through a friend of mine, and we sold it to hospitals like Apollo. So he was extremely enthusiastic in even at that time. So actually, I should give him credit for one most important thing here. So March 23rd, 2020 was the time when I met him. Now, when one of my friends was admitted under his care, I was in the hospital and I used to go to his room to just chat for a few minutes. So at that time, on March 23rd, he showed me a paper by Amici, and he said that this is SARS-CoV-1 effect of Indomethacin on SARS-CoV-1. SARS-CoV-1 has very similar effect, especially after it enters the cell post-entry. So it should work. Definitely, it should work because he said, I mean, he had tons of experience using Indomethacin. So March 23rd, 2020, he told us. After that, in April, there was a paper from China, which actually said that Indomethacin is a very important drug. But interestingly, it was published in medRxiv, and after that, it disappeared. After that, the guys did not publish the paper. They didn't continue. So a few papers here and there appeared, and later, Dr. Ravichandran started using it with amazing results. We're talking about 1 year back. And he published 2 papers with a small number. And I'll just go through what is the evidence quickly and the scientific basis behind it in a more elaborate sense. He had said that already. So I'm reminded of an incident between Albert Einstein and his driver. I don't know whether it's true or not. I'm in the position of the driver, and the Albert Einstein is Dr. Ashsi. So if you have any questions, Dr. Ashsi will answer. So I was just going to present the broad why antiviral. The reason why I'm presenting this, though Dr. Ashsi had already said this, is because a lot of people do not understand the antiviral action. It's a phenomenal action, and all of them look at this as a rheumatoid arthritis drug. So let's just quickly run through the life of the virus in the host cell. So all of us by now know that the virus actually enters through through what is called as ACE2 with the help of a host protease. Protease is one which breaks this out or cuts the S protein. You can see that here. So,
Sir Krishna Kumar, are you sharing your screen or?
Yeah, Professor Krishkumar, I think your sharing is gone.
Sharing is gone?
Yeah.
Can you please share again?
Okay. Are you able to see me? See my screen?
Yes.
Yeah. Now we are able to see the full screen.
Yeah. Okay. Okay. You're able to see my pointer also?
Yes.
Yes. Okay. So this is the step number 1, where the virus enters the host through what is called ACE2 receptors. One second. Okay. So as soon as it enters, okay, there is what is called as cathepsin L, which actually breaks down or cuts open the shell around the virus and releases the most important part of the virus, which is the RNA, single strand RNA. That's a single strand RNA comes out. After it comes out, okay, it actually amazingly uses all the mechanisms of the host cell in order to replicate and get out. So, for example, the code book is opened. Code book is called open reading frame 1A and 1B. That is opened. Then with that, it's translated, and we get some what is called as non-structural proteins, and the non-structural proteins are put together, and we get a replication of RNA in a reverse sense. That doesn't matter. And also, this virus has a number of other parts. what is called as E protein, N protein, nucleoside, nucleocapside, membrane protein, spike protein, all these things, okay, are assembled inside our cell. So the guy uses our cell in order to assemble new viruses, and the new viruses get out. So in other words, our cell becomes a replicating machine. So in order to stop the virus, we have to stop that replication. So there are a number of stages, okay, which I have put forward here, 1, 2, 3, 4, 5, 6, as the stages that are required in order to produce the virus. So the antiviral action is by stopping various stages. For example, you see remdesivir. This is what is called as viral RDRP inhibitor. One of the steps, let's not go into the details of it, one of the steps it stops. Like that lopinavir, favipiravir, all these things stop one of the stages of this viral or viral history, or as it goes into the cell and comes out, the replication. So once one of the steps is stopped, the replication is stopped. But unfortunately, none of these drugs have been found to be very effective. Interestingly, indomethacin has an effect on, it is what is called as cathepsin L inhibitor, which means that it does not allow the cutting opening of the shell, and the RNA virus does not come out. So it actually inhibits that opening and the virus does not come out. So that's the first thing. Then it also, the other thing is that it also is what is called as virus protease inhibitor. So that is a very powerful, 1,000 times it decreases replication by stopping this site. So in other words, it works like something like lopinavir. Then it actually has other effects, which Dr. Ravichandran already said. One of the things which is not very clear is that there are softwares which have shown that it can even prevent attachment. So there are 3 stages at which indomethacin works. Just to expand what Dr. Ravichandran said. So these 3 stages. Apart from that, it also has an effect on the what is called as the cytokine storms. Cytokines are proteins. They are produced due to immune response. They are actually communicators. They communicate or warn other cells of the impending danger. They go to the next cell and say, hey, some outside guy has come, be careful, up your defense mechanism and so on. Sometimes what happens is, especially when there's comorbidity or people who are old, the cytokines are not immediately produced. So they are delayed. They arrive at the scene a bit delayed. So when they are delayed, they get panicked. So they start producing more and more. So in other words, the result is what is called a cytokine storm. Indomethacin is one which stops the cytokine storm, and bradykinin, which Dr. R.C. said, it also stops bradykinin storm. So not only it's an antiviral, 3 most important things that it does, apart from the antiplatelet action, which Dr. R.C. said. So the science is extremely strong. Like, it is the drug which stops all the stages of this disease. So with that, Dr. R.C. recognized that in March, and very unfortunate, very, very unfortunate, people didn't listen to him. He gave half a dozen interviews saying that, hey guys, this is the drug. But it so happened that there were a lot of misconception about it, as he was telling. I just checked, and we found that indomethacin in 2018 was prescribed to 2 million patients in the United States. That means 1 in 150 in the United States were taking indomethacin. So that is the amount of people who have been taking this drug. So, which clearly shows that if it had been such a bad effect in the United States, 2 million people would not be consuming it. So it is an FDA approved drug, which has been said. And what we are looking at right now, which is very important, is Dr. R.C.'s prescription is 75 mg sustained release for 5 days. Imagine or compare this with the usual treatment regime. It's a long-term regime where people give it for months. And after months, people get into trouble sometimes. But here we are looking at just 5-day regime. Okay, so what we are looking at is a 14-day follow-up after that. That's all, 5 days, 14-day follow-up. Let's look at the results now. So in fact, early studies last year end from University of California, San Francisco, who did a retrospective study, found that indomethacin was very effective. Only 1 out of 244 patients who were taking indomethacin for COVID actually ended up in hospital. It's a very powerful thing. This is again was pointed out by Dr. When we were having discussions. He had done enormous literature survey on it. So there have been other studies, actually by Dr. Ravichandran, 2 papers about 2025 very critically ill, that is in other words with comorbidities, these with kidney transplant and all that, those patients were cured by Dr. Ravichandran. And his friend Jonathan Libowitz had used it in 60 patients, and that result also showed fantastic results. With all this, both I and Dr. Ravichandran decided that there should be a trial that should be conducted. So the trial was immediately approved. The money came from Mr. Chris Gopalakrishnan, Distinguished Alumnus Awardee of IIT Madras. 15 minutes, he gave us the money. So amazing. Thank you, sir. If you are here in the meeting, we really thank you. But for you, we wouldn't have been able to do this. So then I have to thank Mahesh, who acted extremely promptly. Within a day, he arranged a meeting with Chris and we got the money. Thanks, Mahesh, for a wonderful gesture. Kamakoti, he's an awesome guy. He was responsible for all the help that I got. He was when executing this project, and with the blessings and with encouragement from Getu. Bhaskar has been the most enthusiastic participant in this whole study. Thanks, Bhaskar, for all your background work. So let's look at now the trial. The indomethacin trial can be divided into 2 parts. First, we did what is called propensity score mass trial. I'll explain this a bit later. This was done sometime last year because at that time we were not able to do an open label randomized control trial due to so many reasons where the government was controlling the whole treatment procedures and protocols. So we were not able to do a complete propensity score, randomized control trial at that time. We did what is called as propensity scored mass trial, which is supposed to mimic the open label randomized control trial. So I'll explain both the trials and the results. In both the arms, we monitor the clinical parameters, that is fever, cough, cold, myalgia, that is body pain. All those things were SpO2, the saturation levels, all of them were monitored every day for every patient. And then the complete blood profile, their blood profile was measured before the treatment and after treatment. So the protocol came from Dr. Ravichandran, and this was, this is what he felt are important things. We measured what is called as a CRP, C-reactive protein, which is an inflammatory marker. We measured D-dimer because D-dimer is important to check whether there's going to be any blood clot that's happening. And because of the negative propaganda against indomethacin, we also wanted to measure the kidney function test, which is urea and creatinine, as well as the liver function test, which is SGOT and SGPT. So these were the blood tests. About 25 to 30 blood tests. I'm not going to go through everything because 25 blood tests were done before and 25 after the patient is through with the treatment. So we collected enormous data. Every patient, there was enormous data that was collected to understand what's happening. So first open label randomized trial was done at Panimalar Medical College. Thanks to Panimalar Medical College and especially Dr. Suresh Kumar, who's here. He did a fantastic work for us. And the site coordinator, Mr. Kumar, I'm sure he's also joined. He's from Ethos Clinical Research. He was the one who actually conducted the trial in the sense that his people measured what is required on a clinical basis. The principal investigator there is Suresh Kumar. He worked with the overall principal investigator, Dr. Ravichandran, and I was coordinating the study along with Dr. Shivakumar Vijayaraghavu, who is also here from Narayana Medical College and is an adjunct faculty at engineering design. He has previous experience in these kind of things, so he is also in our team to look at that. Okay, so 75 mg sustained release with the proton pump inhibitor for 5 days plus standard care against 650 mg into 4 plus standard care. The target was 300 patients, 150 in each arm. and they were done. They were recruited using what is called as block randomized software, generated random numbers, and according to the random numbers, they were allocated either of the two arms. So right now the results are available for 210 patients, which I'm going to publish. So it's a very properly conducted CTRI registered trial. So inclusion criteria, this is the inclusion criteria, and most of them are included. Hardly if they have gastritis or recent heart attack or acute kidney injury, they were not included. So one of the things which people immediately talk about is what is called a sample size calculation. So they say that, oh, what is this? Is this sample size sufficient? They wouldn't have gone through the calculations because of the fact that the calculations, in fact, can be conducted very easily. And it is a hypothesis testing calculation. So we had done a calculation. We found that what is important is the significance level and the power, which is very important, which has to be 80%. And if you have the estimated incidence in the control group and in the case group, then we can calculate very easily. In fact, from a previous experience, we know that the desaturation may happen in about 15% of the patients using paracetamol, and about 3 to 5%. So we had done that 3%, and we found that 90 is a good sample size. And we do also a post hoc calculation afterwards, and we found that for the results which we had, the power was 99%. So it is very simple to, I would say, calculate this. And let me check whether I can even go to that site. So you can actually, yeah, give me a second. I will, are you able to see my screen?
Yeah.
Okay. Now I can do a very simple calculation for you. For example, group 1, I have the number of patients which are going to be affected, say 15. In the group 2, which is what we are looking at, is 3. Okay, and the power is 80%, and alpha is usually used at 0.05. Now, if I do this calculation, you can see the total number is 176, about 88 per group. So the calculation is very simple. As this difference between the two keeps increasing, okay, the numbers keep changing. But the post hoc calculation is, for example, we had 20% in group 1 had desaturation, and 0% had in group 2 desaturation. When I now calculate this, I do it as a post hoc calculation. So I see that only 34 is enough for me. Okay. So in fact, I can do other way. I can do also calculations to determine the power and so on. So the calculations, the reason why I said this is because, in fact, discussions, there are a lot of things about number calculations. So I just wanted to reinforce that it is possible to get these numbers very clearly, calculate them very clearly, that there is no big problems about it. Okay, having done that, let's look at the patient profile at a glance. This is the patient profile at a glance. Okay, we had female to male ratios 82 to 118, total 210 patients. Paracetamol arm, because we had not completed the 300 trials, we had only 210 patients. There's a slight mismatch between the two as per the random number generated. So 108 to 102. So the age, if you look at it, age matches very well. The standard deviations, everything matches very well. You can see that the temperature and admission, fortunately for us, because we're trying to prove that indomethacin is the drug, the temperature admission is higher, in fact, in indomethacin when compared to that of paracetamol. Cough and admission. The cough is measured in a scale from 1 to 10. 10 means the guy is not able to do anything. He's coughing all the time. 1 is perfectly all right. So it is graded from 1 to 10. And we look at the cough to be very severe when it crosses 7 to 10. And 2 to 6 is milder version of cough. So we looked at the number of patients at from 7 to 10 and 2 to 6. And interestingly and thankfully, indomethacin had more patients who had severe cough when compared to mild coughs. So there are comorbidities in both the groups. and the number of comorbidity patients. So we were also looking at how this works with diabetes and hypertension. So the patient profiles, this is the patient profile. You can see that I already talked about temperature. You can see that the CT score is comparable with P is equal to 0.62. That means the difference is not significant, statistically significant. See that CRP at admission, which means that the C-reactive protein, the inflammation levels were also comparable. Cough on admission, I had already talked about this. There's a small difference. Age, there is no difference. And SpO2 on admission, there's not much difference between the two. So we had taken SpO2 from minimum to be 94, and the median is about 95. So now let us look at the results. Let's look at the number of days for cough reduction. Very significant. The left side is indomethacin, the right side is paracetamol. The median time for indomethacin group to get completely cured, because we are talking about when they reach 1, is 4. On the other hand, the paracetamol group, the median time is 7. So in 4 days, all of them in indomethacin, or median time is 4. In fact, 95% confidence interval is from 4 to 5. One of the things we can also notice, this is IQR, interquartile image, which means that 25 to 75% percentile people. You can see this to be small, which means that the spread is very small, and it is also shown by the error chart here. On the other hand, look at paracetamol. People were coughing even after 10 days. A lot of people. So the spread is extremely high, which means that whatever be the background, whether people had diabetes, hypertension, whatever be the age, indomethacin has been extremely effective and could cure it in a very narrow time scales. Let's again, severe cough. You can see that it's just 5 days instead of 4 days. On the other hand, you can see it is 3 days if the cough is less. So indomethacin has worked very well in cough reduction, and this is also because what Dr. RC said is the bradykinin effect. It inhibits bradykinin, which causes the cough. There are 2 effects that bradykinin causes as far as the COVID is concerned. One is the cough, the other is the myalgia or body pain. This is due to the ability, or the bradykinin activates some nerve endings, and because of that, people feel the pain. And if bradykinin is inhibited, then pain is also relieved. So the first thing is cough reduction is fantastic with indomethacin. Let's look at fever reduction. Same story. Again, the gap is very small. You can see it here. Okay, the indomethacin's median is just 3 days. 3 days with 95% confidence interval to be 3, and look at the fever reduction here. So you can see that the fever reduction is dramatic in 3 days, most of them. And again, whatever be the fever on entry, whatever be their background, all of them had very good recovery with indomethacin, which is shown by that smaller error points. On the other hand, look at this. You can see with paracetamol, the people who had fever on 8 days, 9 days, 10 days, and so on. Okay, and so that range is very, very high. So indomethacin is crisp. It acted, reduced fever immediately. And myalgia reduction, same story. Myalgia is body pain. You can see that the body pain reduced with indomethacin very fast, okay, when compared to paracetamol, 4 to 7 days. Yeah, but body pain is a very subjective evaluation, and that's why the spread is very high, because people may feel, to physically or mentally to have body pain. But in spite of the fact that it is a qualitative parameter, the difference is quite clear. Now, C-reactive protein. C-reactive protein is very important because there have been studies which shows that above 40, look at that, scores carefully. Above 40, C-reactive protein may lead to severe disease. And C-reactive protein cannot come to 0. It should not, because C-reactive proteins are important for antibody productions as well. It has to be controlled. In other words, it has to be under check. So if that is the case, you can see that the C-reactive proteins, the change in C-reactive protein, especially in this region, where above 40, which may lead to severe disease, you can see that the reduction in C-reactive protein is very good, very high with indomethacin. Again, look at the R squared. The R squared is 0.85, which means the spread is very low, which means that statistically the spread is very low. On the other hand, if you look at paracetamol, it's 0.1. So clearly, indomethacin again works in reducing QRP, irrespective of the patient's profile. The most important thing, how many become desaturated, which means that the SpO2 levels less than 93, how many of them? This is very important because this may lead to further deterioration. It may lead to oxygen requirement, but since it was in a hospital setting, Panimalar Medical College managed most of them with prone position and so on. So fortunately, in our, no one became severe, but nevertheless, none in indomethacin group required further treatment. None become desaturated. SpO2, for none, it dropped below 94. In fact, most of them were 98, 99. I'm not elaborating that we have put it in the paper. So immediate increase in SpO2. On the other hand, 20 out of 108, nearly 20% of the patients in this paracetamol group, they desaturated to 93 and less. One of the things we found in this desaturation is that if the fever continues for 7 days and more, in fact, 90% of the people of this 20, they had either fever continuing for 7 to 8 days, or they had severe cough continuing to 7 to 8 days. As Dr. RC taught me, that it is the metabolic reactions of fever continuing for 7 to 8 days is not good, and so that leads to desaturation. Very clearly brought out, because it is intertwined. The symptomatic relief and desaturation are intertwined, and that moving. Many doctors don't understand this. Dr. RC is the one who actually propagated this. He said that symptomatic relief is very important because it is intertwined with further improvement of the patient. So that's very clearly brought out here. Once the symptomatic relief, which also means that the patient well-being, the disease reduction, everything go hand in hand, then the patient desaturation is just zero. This amazing result, which I want to emphasize here. Interestingly, a lot of people advised us against looking at RT-PCR on the 7th day because there are a lot of technicalities involved. But in spite of it, just go ahead and look at it. 40% of the patients who are taking indomethacin had turned RT-PCR negative on the 7th day, whereas 28% in paracetamol. The spread is high because the problem also is that at what level, at what viral load they were admitted and so on. Nevertheless, quick look at it clearly shows that a lot more people, in fact, antiviral activity is present. There's a lot more people got RT-PCR negative with that. Kidney liver function test, there's no difference between the two. All the P's are way above 0.05. So there's no difference between the two. The most interesting thing is the 14th day assessment of the patients. So 14th day follow-up was done with every patient, and this is the result. You can see that 50% of patients in indomethacin had complete recovery when compared to about 30% or 31% in the paracetamol arm. Okay, not only that, if at all they had not recovered, most of them were tired. In fact, one of the things we noticed is most of them had gone back home. Homemakers had started working at home. Okay, so the tiredness is a natural process of healing. And so we were not surprised that people who started working were tired. On the other hand, the body pain, the myalgia is only about 14%, and joint pain was only for 10% of the people. On the other hand, look at the joint pain. 42% of the people had joint pain. And almost everybody who recovered, okay, had some problem or the other. So the point is that the recovery here is complete whereas the disease was lingering on even after 7 days. So the other trial which we did, I'll just go through this trial quickly because the results are very similar. Unfortunately, people did not understand what is propensity score match trial. It is a very sophisticated statistical tool which we used. What we did essentially was that this was done at Narayana Medical College, and Dr. Shivakumar is the site coordinator. He is privy to all the data and other things in the site. So we did this, and essentially we admitted patients into the trial for Indomethacin after getting their consent. We told them that this is what we are going to try. If they gave the consent, they are into the Indomethacin now. We did not actually check the patients completely. We just asked them first. If they are not interested, they went to paracetamol arm. Both of them were treated by the same doctor, in the same ward, everything being the same. So in effect, this was also a randomized controlled trial. But since people did not accept it, so we had to do another randomized controlled trial. But you would notice that then we did what is called propensity score matching. Propensity score tells that the probability of being included in one arm or the other is the same if the propensity score is the same. So that is, there's a lot of theory to it. I will not go into those things. We have matched both these very nicely between the two arms, and the number of comorbidities in both cases. And we have data for 72 patients. But here, this was in the first wave. This is also very important to understand. In the first wave, the treatment protocol was slightly different. When the SpO2 levels dropped to 93 and less, people immediately were put on oxygen, which they did not do in the second wave due to so many reasons. So here, we had looked at, again, the number of oxygen requirements between the two groups. Phenomenal, 34% to 0 in Indomethacin. So again, it's the same case that people were saved of going into oxygen and severity. So in fact, when people were admitted with dyspnea, which means that breathlessness, that's different from hypoxia, with dyspnea, you see that in paracetamol arm, all the guys all the patients who were admitted with dyspnea actually required oxygen after day 1. On the other hand, one treatment with paracetamol, with the Indomethacin, only one of them required oxygen for 1 day. See, and the rest of them did not even require oxygen. So again, the results are very similar to what we have in the second wave. The reason why the results are going to be very similar is that, look at that. So the days for fever reduction, you can see that, again, we'll come to the severum in a minute. Indomethacin and paracetamol, fever reduction, big gap. Cough reduction, same gap. Mild GI reduction, there's a gap. So the results were very similar even in our first wave. The reason is that Indomethacin works not by forming or attacking the virus even before it enters. So it is not like an antibody, monoclonal antibodies, MABs as they call, monoclonal antibody treatment. It is post-entry treatment. So post-entry doesn't matter. So it works in whatever be the variant. The treatment is independent of the variant. Worked in variant, the first variant, worked very well in Delta variant. So it is agnostic to the variant that you're treating. And this is good news because whatever be the variant that you're going to get in future, Indomethacin is the solution thanks to RC. I would say the whole world, he's the only guy who's been telling about this, and I've just been the squirrel in Ramayana and just helping him. He was the only guy in this world that was telling that Indomethacin should work. It has all the theory. Now we have been in touch with Gabriela Santaro, who first wrote the paper. And in fact, she was astonished with the result. She was the first one who said post-entry Indomethacin should have an effect. But we've been in touch with her. She's been pushing me to publish this. And this is, I should give all the credit to Dr. Ravichandran. So that's the results. And then we did a very interesting trial. We wanted to look at in severe patients already admitted in oxygen. Okay, will it work? Oh, that was a question which we asked. Fortunately, we did this in a set of patients in Datamage, 22 patients who were already in oxygen, high flow oxygen. And interestingly, we found that they didn't have, please note that they did not have steroids, they had only remdesivir. Okay. We found that none progressed to ventilator. All of them came out. Okay. Because they have, some of them were in high flow oxygen. So this is the time for discharge, not from ICU actually, sorry, from the hospital. So many of them had 13 and 14, they just got discharged on the same day. So all of them recovered. That was an amazing result again. So in fact, safety profiles in the first wave is also similar. There was no adverse event except one person who had a chronic kidney disease. His creatinine was elevated, but he became okay in 14 days. In fact, when we published this in MedArchive, look at that. This was in the 96th percentile and the top 5% of all research outputs ever tracked by AltMed, which means that, I mean, this was closely followed by so many people. I got so many mails, but unfortunately, we being an education institution when can only give a proof of concept, we're not in a position to prove with 2,000, 3,000 patients, which requires crores of rupees. So unfortunately, people were not taking it up for various reasons, which we can have a separate debate. So why would indomethacin work in the severe cases? We are now proposing a trial. We have proposed a trial with Adis Engineering Medical College in Mandya. And it's a very, again, we were bold enough, thanks to the guidance we are getting from RC, that we are going to try severe cases. Why is that working in severe cases? Because people don't understand that there is a difference in the type of what you call as ARDS, acute respiratory distress syndrome, is different for pneumonia to COVID-19 and in high altitude pulmonary edema. So they are different. In fact, there's a very interesting paper in Circulation last July, which showed that they are different. Why am I insisting on this? It is because you see that it is this guy HPV, which is absent in COVID-19. So hypoxic pulmonary vasoconstriction, which is called HPV, is absent. And that's a very important thing. So what it does, so the problem is with COVID is what is called happy hypoxemia. Happy hypoxemia means that the guy is not breathless, doesn't feel breathless, but his SpO2 levels go down. This is because of the body's failure in hemostatic oxygen sensing system in COVID. So there is a mechanism by which our body takes care of the lungs when there is an oxygen depletion. This is due to what is called as hypoxic pulmonary vasoconstriction. So is the response of the body, HPV. So there is a vasoconstriction, guys. See that there's a pulmonary vasoconstriction. It constricts the pulmonary arteries, serving the hypoxic lung segments, diverting the blood to better ventilated alveoli, optimizing ventilation and perfusion matching. So there is a profound impairment of HPV in the case of COVID-19 patients. In fact, the paper goes ahead and recommends that don't try out vasodilators. It's a very interesting statement. I don't want to go into that further. Vasodilators. Paper also says that inhibitors of endogenous vasodilator pathways and COX pathways, which are basically done by indomethacin, can also be a very powerful tool to counter COVID-19 induced pneumonia. So that's the reason why we are going to try this out, and we hope we are successful. So in conclusion, we feel that indomethacin 75 mg/SR should be used in mild and moderate cases till we prove that it can also be used in severe cases. There's no contraindication. In fact, there have been enough data with our group, including Dr. RC, in treating even severe patients, but we can't let it out unless we do a controlled trial. But our data, what we have, has given us the confidence that it will also work in severe cases. This will lead to rapid reduction in symptoms, leading to less hospitalization, less spread of infection, and it would, in my opinion, would become like a common flu at the end of the day. Thank you very much. If there are questions, we can take. And I would like to share the experience of two other panelists who were actually these soldiers in the wards. Dr. Suresh Kumar is with us. Dr. Suresh Kumar, you're able to unmute? Yeah, he is a professor of medicine at Panimalar Medical College. And can I have a few words from you, sir?
Yes, sir. Good evening, everyone. I am Dr. Suresh Kumar. I am working as an assistant professor in Department of General Medicine in Panimalar Medical College. IIT Madras and MEOT Hospital approached us for this study, Indomethacin for mild and moderate COVID-19 patients, to assess the safety and efficacy. We had a difficulty in approaching the patients to convince them, to tell them that this is a new drug, which is, it's an older drug, which is not used in COVID patients in particular. We were able to convince few patients, and many of them didn't get convinced. And Indomethacin, we have been using Indomethacin for various indications, as Dr. Ravichandran sir said, starting from migraine, for any joint pains, for stopping the rejection in renal transplant, for plantar fasciitis. Indomethacin has pleiotropic effect. In COVID-19, also it has a pleiotropic effect by reducing the interleukins, by reducing the viral load, by reducing the cough, by reducing the fever. Symptomatic relief is there in the patients. We were able to enroll about 200 and 300 patients, 210 patients reports are available. 108 patients were in the paracetamol arm and 102 patients were in the Indomethacin arm. Dr. Krishna Kumar sir would have explained about the study design, the results, and the endpoint assessment. As you can see, Indomethacin works very good in mild and moderate cases. We have to see the effect of Indomethacin for severe cases. It will be a boon for treatment of COVID cases, since the life-saving drug for COVID patients right now present is only steroids and this monoclonal antibodies. Indomethacin should be studied vastly in COVID-19 patients so that we can publish that and we can add that in the ICMR treatment regimen, MOHFW's treatment regimen for COVID-19. So the patient can be benefited very much and we can stop the deaths of many patients. That's all.
Thank you. Thank you, sir. Dr. Shivakumar, can you add a few words?
Yes, sir. First of all, I would like to thank Dr. Krishna Kumar sir for introducing me to this wonderful project and to the IIT community. And I owe a special thanks to Dr. R.C. sir for interacting on a regular basis and educating us in this project. So I am very fortunate to take this study in a time when no one was not knowing much about the Indomethacin other than the R.C. sir and KK sir, Krishna Kumar sir and us. When we initially did the study, we thought like it's like any other doctor, our PA, we also thought that it will be an anti-inflammatory drug. It will not have much of the effect. Symptoms may not be reducing, but anyhow, it's a study from IIT Madras. So why don't we give a try for it? And the literature was also supportive at that time. And we started the study. And to our surprise, in first 10 patients, we saw the huge difference. The results has been shown by our beloved professor, Krishna Kumar sir. There is a huge gap between this paracetamol and the Indomethacin arm. We see the patients are recovering faster. It's like a magic happening. Like the patients are recovering from the fever in 3-4 days. cough is getting reduced in 3-4 days, myalgia is gone. Like the patients are asking, what is this? Like my myalgia is gone, my body pain is gone, can I go home? That is the first word they ask. We say, no, you have to be in the hospital for 5 days, and we discharge them at the 7th day. And other arm, the paracetamol arm, since the ward is same for all the patients, the other arm, they started asking us, doctor, you are giving some medicine to them, they are happy, they are recovering, why you should not give the same to us? Because it's a trial study, we have ethical committee clearance to give so many number of patients only. We with cruel art, we denied them, like we were not able to take them at that time. And we by ourselves was surprised, and I would say this is a drug. In addition to the list of antiviral activity, explained by Dr. Krishna Kumar sir. So he showed like ACE2 inhibitor, it inhibits the cathepsin L and all those things. There is an interesting study done in Korea where they took all 20 anti-inflammatory drugs, 20 different anti-inflammatory drugs, and they studied its activity using a network analysis. So in that, what they found is indomethacin, roxy, and then 6-MNA are these three drugs which were inhibiting the apoptosis in the cells. Of this, indomethacin is more potent. It inhibited BCL2 associated agonist cell death. That means what? If the virus is if the cell is highly infected with the virus, the cell can go for apoptosis, it can die. So thereby there will be a large number of cell death in the organs. So indomethacin could inhibit such kind of an apoptosis by inhibiting the BAD protein. So that is one of the scientific thing. And I'm also coordinating along with thanks for RKK sir, that is R Krishna Kumar sir, for allowing me to continue with him to take this journey. And I would say indomethacin is a miraculous drug, as Dr. Suresh pointed out. This should be done in severe cases, and it should be in all the governmental regulations, and it should be given to all common people so that it can we can alleviate this disease. I myself personally took indomethacin when I had a COVID kind of a symptom. It works very well. With this, I would like to, with a thank you note, I will finish it here. Thank you, sir.
Thank you, Dr. Shiva. Back to you, Ratnakumar.
Thank you all. It was an excellent talk. We really enjoyed it. So if any of the attendees have any questions, they may raise their hands and then we can unmute and they can ask. While attendees try to figure out how to unmute, so what would be may I ask a question while attendees try to figure out unmute, sir? So what would be the next step, sir? How would we think about taking it forward, and what are your plans for that?
Dr. Asi, the questions Dr. Asi will take. Yes.
Yeah, I think we are now going to put it, get it published. Of course, straight away we will load it in the Med Archives, but we'll try to get published in one of the top journals in the world. I think that's the only way we can get the attention, because in various guidelines, still it says indomethacin requires further evaluation. So I think this further evaluation is over. We should now make people aware that it should be used. And I would like to add to what has already been discussed. Now, I think you must have heard of a thing called long COVID. That is, patients who recover out of COVID, the symptoms persist for a long period of time. Now, I have followed up in those patients who have received indomethacin, and none of the patients have any long-term symptoms. Not only that, there is not a single patient with diabetes or fungal infection, and all of them have formed antibodies. So this is not like steroid, where it is going to suppress the general immune system itself, so that you are prone for all complications in the long run. So I think again a very, very important point that indomethacin has a value even for the long-term outcome of COVID.
Very nice. Um,
In fact, Dr. RC, in clinical setting, he has treated maybe 300, 400 patients. And all the comments were just awesome. So he has followed it up. And sir, you have to also tell about the antibody formation.
Yes.
Yes.
And another thing is, one of the nephrologist, rather the head of department in the government hospital, and when he got COVID, he took indomethacin. He sent me a message, sir, it's a magic bullet.
And also antibody formation.
Antibody, all of them form antibodies. Well, so and the antibodies, the spike protein antibodies, their levels are very high. Those patients who have received indomethacin, so it is not suppressing the antibody formation at all. So I think, and it doesn't interfere with vaccine. I think it's really a tailor-made drug, as I said. I always been feeling right from beginning that this is the drug for COVID-19. Yeah.
we have a question from Dr. Srikanthan.
Hello, Professor RKK. When we publish this paper, do you expect any pushback?
What do you mean by pushback?
Let us, if there is any response from the medical community about, maybe preconceived ideas about indomethacin. So
Yeah, that's what Dr. RC was also telling. That is why we had done liver function tests, kidney function tests, all those things to show that there is no effect. And added to the fact that there are 2.1 million prescriptions for this in the United States, and that is not for 5 days. That's for a longer time. The most important thing is that is for a longer time. So I don't think that once this is published, there can be any questions about it.
No,
okay, sorry, sir.
Dr. RC to add, yeah.
Yeah, I would like to add. See, my assessment is that the lack of prescription of indomethacin is because the government is insisting on following its protocol, both in the ICMR or the Ministry of Health, and their protocol does not contain indomethacin. So this makes the patients, the physicians, little reluctant to use it when it is not in the protocol. They are very well ready to use hydroxychloroquine, ivermectin, or whatever, doxy, so many other drugs, but they are worried of indomethacin. So I think it should come in the protocol, and for that, it's very important that the paper is published in a very leading journal, so that the government has no choice. It's left with no choice.
Okay. And is there a timeline which you predict for this to be, with the government, come under government protocol?
I think we have been having meetings with the ICMR. Unfortunately, we had this, I think Kamakoti must be there. So we had this meeting with all the people of ICMR, the Niti Aayog, Ministry of Health, Principal Scientific Advisor, everything. So ultimately, the ball was pushed to the ICMR, and they said that the Director General of ICMR will take action. And the Director General has not answered. I just got a mail saying that we will have a discussion with the therapeutic task force, but there has been no contact further from the therapeutic task force. And I have sent the reports also, the latest trial of the RCT. I have sent it to them a couple of days back. Still, there is not even an acknowledgement that I have sent any material to them.
I see. Thank you so much, sir.
Yeah.
Dr. RC, can you add that there's one other thing that unfortunately early on March last year, 2020, there was a note that NSAID should not be used, and many people still are following, including ICMR are following that. Yeah, can you add?
So now they have changed in their guidelines, and they have now said that including the WHO, UK, Europe, everywhere they have changed. See, this was a unfortunate paper, which was not a study. It was just a postulation saying that non-steroidal anti-inflammatory drugs can give more access to the virus. I don't know how that man put it. That is early in February 2020, he published in BMJ, saying that a postulation he created, saying that non-steroidal anti-inflammatory drugs might worsen the proliferation of the virus. So, of course, after that, there has been several refutals and all of them have withdrawn now. Now, all the guidelines say that non-steroidal anti-inflammatory drugs, it's left to the judgment of the clinician to be used.
But unfortunately, ICMR last month released saying that NSAIDs should not be used. I mean, that's not a correct thing that should have been done.
There is a question from one of the participants, admin, with the name admin. You can go ahead.
Yeah. Hi, sir. Kishore from IIT Tirupati. So my question is Indomethacin is used for renal replacement therapy in the CRRT patients while using COVID.
I'm not able to get your question.
Yeah, I'm not able to hear it.
So the patient is in CRRT. In that condition, he is having the COVID. In that situation, you are using the Indomethacin. Is a drug of
Yes.
choice.
Do you mean to say the patient is under dialysis and can he use it?
Yes. We have used on dialysis patients also. We have
Okay.
used that publication of short reports of 17 patients. Some of the patients were on dialysis, and even renal transplant patients I have used.
Okay.
Dialysis patients, actually, it is very safe to use Indomethacin because we have already been using the nephrologists are fairly conversant with the use of Indomethacin for pericarditis in dialysis.
Okay. Thank you.
Professor Mahesh, I have allowed you to unmute. You can ask your question by unmuting.
No, I can't speak. So,
Oh,
my microphone. Am I audible?
yeah, you are audible.
Okay. No, I was just wondering, as a way forward, I'm just wondering if you should create a community of doctors to rally around this or around the study. Obviously, the data is very compelling. What can we do to create a community of doctors to rally around this cause? And then eventually, the material can be sent to. I mean, eventually the message will go to ICMR that there is a community of doctors.
Right now, what we have done is the previous study, which we did the propensity score matching, and we are trying to it has been accepted for publication in the Journal of Indian Medical Association. Now, the JIMA has several lakh general practitioners or doctors are members. We are expecting it to come in the July publication. It's still not released, but it has been accepted. So I'm sure that will make a lot of doctors aware of the use of, because personally, I know so many people who have contacted me, doctors who have been using Indomethacin and getting back to me saying that, sir, the results are very good. But everybody's reluctance has been that unless the ICMR guideline, they are all scared of the government. Basically, they want the government to include in the guideline. If it had been any other disease, they would not bother. See, in COVID, what has happened is the government has been harping that they should follow the government guidelines. Every COVID hospital has been told that they should. It is so unfortunate that even in my own hospital at MIOT, once they get admitted as an inpatient, I am not able to use Indomethacin. All my data are patients who are outpatient, where the hospital doesn't have it, because the hospitals try to follow the protocols. Their reimbursement, everything depends on protocols. The state government, last year, actually, we went right up to the top ministry level, and there was a plan that my suggestion was, when the corporation is going house to house for fever, they should take the RT-PCR and give a course of Indomethacin to the person. That's all. What you require is no hospitalization. He is going to improve in 5 days. He is going to be all right, and the cost is going to be only 50 rupees for the government. So the commissioner of corporation came and met me, Prakash, but nothing happened further. This was done about 1.5 years back, 1 year back almost.
And just to add to what Dr. I said, the price of this whole treatment is less than 100 rupees.
Very nice, sir. Very enlightening talk. We really look forward to this changing the course of this particular disease that has really wreaked havoc over the entire world. So we really hope that you're all harbingers of a new hope, as if I may put it that way. So thank you so much. It was a very enlightening talk. Really learned a lot. So we have recorded it, and what we will do is we will also circulate it through other channels. And if there are other questions, we will give some email addresses. If there are other questions, we will just forward it to you at a later date with a request to kind of answer when possible. So if no other comments, I'd like to close the session with a big round of thanks and applause to the speakers and all the panelists.
Thanks, Professor Srikanth. Thanks for the opportunity. And I should thank Dr. Suresh Kumar, Dr. Shiva, and of course, Dr. RC and me, we are together in this thing. So, he's been the guiding light, and it's been an experience. It's been a huge experience doing this. I bugged both these doctors, Dr. Shiva, I bugged him so much for data, as well as Dr. Suresh. My apologies for pushing you like that, but they were also enthusiastic. Both of them were giving in fact, Dr. Shiva knows it, on an everyday basis. I was following. I would ask him what happened to Varalakshmi today. Sir, wait, sir, I'm just giving the data, you would say. So, we had Dr. Shiva, we had a very fruitful collaboration. Thank you very much. And unfortunately, Ms. Kumar has not joined. He was the one who actually was giving us data from Panimala. And in fact, every day, night, I used to appraise Dr. RC because I didn't want anything to go wrong. His guidance was important. And I was also bugging him every day.
8:30.
8:30, yes. 8:30 every day. Thanks, Dr. RC.
See, we are struggling to get the drug.
Yeah.
It could have saved so many lives. My only remorse is that it could have saved several lives.
Yeah. Hopefully, going forward, it will do so. Thank you all very much for joining.
Okay.
I wholeheartedly thank Dr. Krishna Kumar sir for giving me this great opportunity to work with him. Thank you, sir.
Thank you. Thanks.
Thank you.